On this video, we will see in details the difference between the use of the flame bar and the use of the bath bar. We have already spoken about the phase 3.0 of the vertical approach. I want to do a fast recap of this part. So, in 2017, we have improved the original technique with 3 new features. The bar protocol that we will see in details in this video, the ability to do a minimal preparation with this kind of drilling protocol, and our possibility to do our new concept of vertical crowns. The ability to do very thin crowns with axial walls less than 1 mm, thanks to our new lab protocol. So, the bar protocol, the minimal prep ability that opens a new field about minimal prosthetic dentistry, and the verti crown that is very linked to the minimal invasiveness protocol. And we are the first in the world to develop a vertical protocol for the lab. All protocol designed just for vertical preparations. So, about the bar protocol, let's see this in detail during this video. It's very nice, this sentence of Arthur Conan Doyle about the world is full of obvious things that nobody ever takes care to observe, because this is what happened with the use of the bar in the field of vertical preparations, and you will understand exactly what do I mean by a few slides. When we do a vertical preparations, we know exactly what we want. We want a perfect vertical wall, okay? But the problem is, how do we arrive at that kind of result? Because if we use the flame bar, that it is the flame that has been used for decades for obtaining this kind of vertical preparation. The bar has a shape, we have diamond along all the length of the bar, and there is the shape like this. So what happens? That when you use this bar with its axis, you print the shape of the bar on the tooth. And so what happens? That you, using this bar, you will obtain something like this. You will obtain a chamfer preparation, maybe a long chamfer, but always a chamfer preparation. This is something that's not new. This is nothing new. There is nothing new. This was perfectly recognized in the past by people that was using this protocol. And to overcome this kind of problem, they were using this technique, the so-called toe-heel approach. The toe-heel approach is a preparation strategy that was used to overcome the problem related to the use of the flame bar. Let's see in details what is this technique about. You can see here you have the normal steps of prosthetic dentistry. You do the growth reduction, removing the convexity, the belly of the tooth on the buccal wall, on the palatal wall. We do the interproximal separation. When we do anterior, we always stay careful about giving two opposing walls and not to do something like this on the area of the cingulum. But you see on the image on the right, you see that we have a sort of slight long chamfer on the buccal side. And here is when we want to move subgingivally our preparation, and we want to remove this sort of chamfer, that the so-called toe-heel approach comes. Here is the image of the toe-heel approach. So we have this sort of small chamfer. We want with the bar to go below this sort of chamfer. I will show you better in details in the next slide. In order to cancel this kind of chamfer, and to do this, we have to start with this sort of angulation, and after you have to go back, you have to go again to the original axis of the tooth in order to match the belly of the bar with the long axis of the tooth. Let's see this in detail. This is the most important image of the toe-heel approach. Look at the image in the middle. You have to go below the chamfer, and you have to touch the chamfer with the bar but without never touching with the tip the root. Otherwise you will start to scratch everything, and you won't be able to make it smooth unless you do a lot of dental preparation. And after, from this position, you have to go back to the straight axis, the original position, in order to match the belly of the bar to the vertical wall of the tooth. This is something that it is very nice on dental books. It's something that it's very nice to teach at words. But in the reality, doing this approach exposes ourselves to a lot of clinical problems. This is, I want to highlight again, the main problem of this kind of approach. You have to go inside without using never the tip of the bar, and you have to go straight again without the correct angulation. Otherwise, we will have clinical problems that I am going to explain by few slides. So, let's see what happens in the real world doing this kind of approach. If you tilt the bar a bit too much, you will start to use the tip on the root and you will start to scratch everything. You see, something like this. And if you scratch, it's very hard to make this surface smooth again, unless you start to prepare a lot. Again, you tilt and you scratch. We have already seen that if we use the bar in a very straight approach, we will end with a chamfer. This is clear because we print the shape of the bar on the abutment surface. But let's see now in details what happens with the toe heel approach. With the toe heel approach, you go below that sort of chamfer, and after you go again back straight with your bar. Okay? But what really happens? If you go straight, like I did in this case, this is what you have. This is the outcome that you have using this kind of technique in many times. You get a sort of double line, and in that point, in many cases, almost always, because we have to deal at 360 degrees in this case of crowns, you will have an undercut, and your technician often won't be able to go over this undercut with your crown. So what happens? That you think that you have worked subgingivally because your bar was subgingival, because there was blood maybe, but your dental preparation is not subgingival because there is an undercut. So you will see that this sort of double line is very hard to recognize visually unless you already know about it. But your lab instead will complain because when they put this work on exocad or they put some wax and they try to remove, you will see that there were some distortion, or exocad will tell you that there is an undercut. I will show you a case. This is a case of an upper premolar. Look this case, here I did a vertical preparation of this premolar. Look these photos. I have highlighted with this red dot line, this line. This is the area where I did my double preparation. I will show you on exocad this. Look distally, these sort of notches. These are the scratches that I did with my bur's tip. Because when you do that kind of rotation from buccal to distal, from distal to buccal, it's very easy to change the angulation of the bar and to use the tip of the bar. You see, this is scratches I did with my bar's tip. And this is the image of this tooth on exocad. You can see here that I have two lines. A red one, the red dot line, and the black one. The red dot line is the most apical part of the impression, and I've been able to arrive in that area with my bar, but with the wrong angulation. The black line instead is the undercut, is what I explained before, the area of the undercut. And this happens many times when you work according to the conventional protocol in teeth without periodontal problems. When you have a tooth without periodontal disease, you have a small sulcus, let's say 2 millimeters. And when you work with your bar, doing this sort of motion in these 2 millimeters, because of the size of the bar, in most of the cases, your double line will be placed juxtagingival to supragingival. And this will be a problem because your crown won't be able to stay subgingival. So everything is about the undercut location. If the undercut is placed subgingivally, you have already a problem, maybe, on this image. But clinically, your crown will be able to arrive subgingivally, and so you have no more a clinical problem. So what happens? That after the first attempts, and where you recognize about this problem with your lab, with your technician, what people usually does to overcome this kind of problems? The first problem is you recognize that you have not been able to go enough following the first preparation, and you do it more. Doing this, of course, you have no more the problem of double preparation, this sort of preparation, but the problem is another one, that doing this, you end up with doing conical abutment, and you have problem about stability of the crown, problem of decementation, and when you connect multiple abutments, like when you are working with bridges, you can risk on some abutments, you have a high risk of decay. Or the other solution, you recognize that if you start to work deeper with your bar, you have no more technical problem. This happens because you always do a small chamfer. You have an undercut. You have a double line, but this is placed so close to the bone crest that after the healing, all that area will be hidden by soft tissue. Something like this. If you have in that point your undercut, this is no more a clinical problem. Because after a healing, after 3 weeks, after 4 weeks, you will see only a vertical wall. And when you will do your impression, you will see only a vertical wall. So what is the problem of this approach? The problem of this approach is that with your bar, you have been able to arrive to the green line on the bottom of the slide. After the healing of the gingiva, you will be able to record till the blue line. The blue line is the most apical part of your impression. Usually in vertical preparation, when we have a sufficient height, we don't use all the space that we have in the impression in the sulcus to do the crown. We use something less. We will see this in other videos in details. The black line is the juxtagingival line, so we have the black line, the juxtagingival level, and the blue line instead is the most apical part of the impression. We use something in between, and you can call this in this slide the red line. So you drill till the green line, you impress till the blue line, but for doing your crown you will start from the red line. So you prep much more than you impress and use. There is a huge part of the tooth that has been drilled without a purpose, just to overcome the problem related to the shape of the bar. This approach, the conventional one, is named edgeless approach, because when you do your impression, we have already explained that you have a vertical wall. And on this vertical wall, you can close your crown at every level that you want. Blue is the most apical level, black is the juxtagingival level, and you can move along this surface. This ability to move along a wall is named edgeless approach, because you have just a flat area and you are moving along this surface. I just want to show you this image that I was able to obtain from a congress in Italy at the beginning of this year, and you can see perfectly where the bar has been able to arrive looking at these X-rays. Look, And you can see exactly where the crown will start its emergence profile. And you can see that there is a huge difference between the area that has been drilled and the area that you are using to do your crowns. So the problems that we have using this kind of approach are many. If you use the bar in a straight motion, we have a chamfered finish line. If we use the tip, we have scratches with the tip. Many clinicians recognize that using small bars, the tip is so close to the root that it is very hard not to scratch the root. So most of them end up using big bars. This is good because it's much more easier not to use the tip and scratch the root. But using big bars, usually you end up doing a bigger tooth reduction with other kind of problems like excessive drilling, especially on the neck of the tooth, in the so-called area of the pericervical dentin. And this is an area that from a biomechanical point of view has a lot of importance. There is also the problem of this approach that you have a lot of trauma to soft tissue, there is a lot of bleeding, and that you have to wait at least 3 weeks before being able to do an impression. So this is the reason because we decided to move to the flame bar, we decided to move to another kind of bar, the butt bar. So let's see what happens using the butt bar. When we use the butt bar has a vertical geometry. So when we move the butt bar, we print just the shape of the butt bar, that it is perfectly a vertical wall. This is what happens. If we tilt the bar, we can't scratch because there is no diamond on the tip. There is no diamond at all. Because we have a tip without diamond, we have not the problem of this tip with diamond working inside the soft tissue, and that we have to keep as far as possible from the root in order not to scratch the root. So the invasion of the soft tissue of the sulcus is much less. The smooth part of this bar has a very interesting ability. The ability to open the sulcus. We will see this in clinical case. I want to do a close-up of this area. Look, when we remove the bar from the tooth surface, look, this is what you obtain. We have an edge. The edge is not a point that we are preparing. The edge is the end of the preparation made with the bar, and this is the point where again the normal undercut, because of the natural shape of the tooth that it is conical, start. So we have this kind of point that is named edge, and we can use, especially in our minimal invasive protocol, this edge to start our crown. This is because when we do our minimal invasive approach, we name our technique, the prosthetic approach is named edge approach. The interesting feature is that the tip without diamond is able to open the gingiva. And doing this, we are able to record with our impression a small part after our dental impression. So the tip, the smooth tip without diamond, is not able to work on hard tissues, but is perfectly able to work on soft tissues. So with the Tomorrow Tooth protocol, this is what we do. We are able to prep less and to impress more because of this kind of approach. So let's see again this in details. Tomorrow Tooth approach on your left. You prep less and you impress more. And for your crown, you use just that part of tooth that has been reduced. And when we do, especially the minimal invasive protocol, we do an edge approach, because again, we have an edge. It is the point where our bar has finished to work, and we have again the natural conicity of the abutment. With the conventional protocol, instead, we have another kind of situation. We drill till the green, we wait the healing, after 3 weeks we take our impression, we record till the blue line. For technical reason, we will use, for example, the red line for our crown, so we prep much more than we impress and use. Because we work only on a flat wall, this approach is named edgeless approach. In our approach, what is interesting is that we can move between these two approaches in relation to the clinical needs that we have. What I mean? This is the image I showed you before. We have the edge. If we go deeper with our bar, with the butt bar, obviously we will move the edge more cervically, okay? Like I did here with this blue dot line. Look here. But if we go a bit too much and our edge is located too deep in the soft tissue, like it happens with the conventional edgeless approach, we are not forced to start our crown from that point, from the edge, but we can move on the vertical wall where we have above the edge, because above the edge we have again a vertical wall. And we can do something like this. So even if we have an edge, we can always use the edge strategy in order not to have a too deep crown. Okay? We will see a lot more about this. Because you will see now some clinical cases, the question usually that attendance that people does is, how is this drilled area without the crown? How is this drilled area towards soft tissues? Here you think that we have a sort of notch, we can say, a sharp point that may be harmful for the soft tissues. It's not. You will see that the edge is something that it's very hard to recognize, very hard to see. And that part of the tooth, even if not covered with the crown, is perfectly suitable for soft tissue. I just want to show you a case where I did a supragingival preparation for a supragingival crown to show you what this edge is in the clinical view. This is an upper bicuspid that for aesthetic reason I did this sort of supragingival crown. Look here, where I did the red line is the famous edge. Look here from the palatal view. Look this image carefully and try to recognize the edge because it's in front of you. This is the edge, okay? You are not able to recognize the edge as a point, okay? It's just a point where from a sort of angulation you go back again with something one. You have to think that with provisional crown, with the flexibility of resin, you are able to overcome, for example, this edge. But you are not able to do something like this with rigid material like PFM or zirconia. Look here buccally. Do you see the edge? It's not a sharp point. Here the edge is just the end of a curvature and again the natural curvature of the tooth. I show you. This is the line where our edge is. And this sort of surface is perfect for soft tissue even if subgingival. The advantage of doing this approach is that you save a lot of tooth, because to bring this preparation to the gingival level, look on the red line how much tooth structure I have to remove. In this case, this patient was an old one. I told him he had also a very low smile line. He was not showing even his upper anterior teeth, so the premolar was completely hidden from the view. And I told him, we can do a crown in two ways. We can do an aesthetic one, but I have to drill more the tooth and it will be weaker. Or we can do a very strong one, but we will lose something on the aesthetics. And the patient asked me, no doctor, It's fine, it's okay, let's do the tough one. And this is what I did. This is, you see, a supragingival crown. We lose something about aesthetic after a discussion with the patient, but this tooth is literally unbreakable, okay? And here you can also see another question that people make me. I mean, what is the emergence profile that we have on vertical preparation? Because people tend to think that there is a sort of a hovering. Instead, it's something like this. It's just about having a convexity at the beginning of these kind of crowns, that it is very similar to the normal natural anatomy of the cement enamel junction. And this is something that is perfectly accepted by soft tissue. I just want to explain, for example, this is the study of Rex Ingram made on some beagle dogs. They did the preparation with the chamfer bars, torpedo. And look here again, even if the edge is much more present, we can say, is much more sharp. After 3 weeks, the healing that we have over the edge, okay? Over the edge, we have a perfect healing of all the parts that our periodontium is made. Look here, we have perfect epithelium attachment, okay? You see, the problem is, at this point, we will see this in details in next videos, but where to place the crown? Because if you do an immediate impression, when we do something like this, our impression will arrive till the edge. But our crown, where will have to finish? We have not to arrive to the edge in this kind of cases, because the edge has been placed for a mistake or for obtaining much more space, prosthetic space, or because we were dealing with a deep decay, but we have not to look always for the edge. We will see this in a better way. So this is what we have to do. We want the tunnel crown will be in the sulcus after the healing. And this is the reason because we will speak a lot about when to do, in another video, when to do the immediate impression and when to do instead the delayed impression, because we have different timing according to the drilling protocol and according to the clinical situation. So we can say that the main differences between these bars are: with the conventional approach, with the flame bar, we have a chamfer bar used with double inclination. This leads to an unpredictable marginal geometry. We use an edgeless strategy and the impression is always delayed. The butt bar, instead we have a bar with a safe end tip without diamond. We have a vertical marginal geometry because this is the shape of the bar, just a vertical wall. We can work according to the depth of work of our bar. We can move from an edge to an edge strategy, and we can do an impression that it is immediate or delayed according again to the work that we have to do. I want to do again this concept because I see that this concept is not so easy to understand, especially for newbie. Again, I did my preparation, okay, but I can prepare more with the butt bar. We will see that to give more space to vertical preparation, we have to go inside the abutment and going deeper. We go like this, not like horizontal preparation, to go inside the tooth. With our approach, we have to go deeper. So what happens? That doing this, our edge will start to be located always in a more cervical position, something like this. But we are not forced, if that point from a periodontal point of view is too deep, to arrive to that point with our crown. We can move along the vertical wall that we have above our edge and move in this way to an edgeless strategy. Okay, so we have an edge strategy when the edge is located in the correct position in the sulcus, to an edgeless strategy when the edge is located too deep in the soft tissue. Let's see some clinical case. This is a case of a deep decay on this molar. I've been able to obtain the isolation using a clamp 212 for anterior. I used some liquid dam in order to get isolation. I did the soft tissue trimming. I've been able to obtain the isolation using a matrix. This is a Garrison matrix, a purple one. This is not blood, but it is the color of the matrix. I have been able to obtain the isolation putting some Teflon between the matrix and the interproximal space. And this is the end of the first appointment, okay? I trimmed the vertical wall in the distal side till the bone crest, because the decay was very deep. Look here what I did. I arrived almost to the bone with my bath bar, and I trimmed all this wall. At this point, so I did the distally, I did the edgeless approach. I arrived very deep, and after the healing, I will do the impression of the vertical wall, and I will place the margin of the crown where I want and where I need. This is after 20 days. You see that after 20 days from this sort of soft tissue harming, we can say, we have the perfect healing, even in the area already prepared with the vertical approach. I do at this point, I did my preparation, and look here. I use different margin strategy according to the wall I'm dealing with. Lingually, where I have an aesthetic, and if the height of the abutment is enough for retention, I stay supragingival. You can see this because you see that there is no blood on the lingual wall. Okay? So I did a juxtagingival edge. Distally, if you remember, 3 weeks before, I already did a very deep preparation. So I just used the smooth part of the bar in order to open the sulcus, in order to make an easy impression. And it also buccally, because I had the area of the furca, I did this kind of equigingival preparation without going deep. And here you can see the famous edge. You can see the edge. The edge, I remember, is not something that we prepare like we do with the shoulder, but it's just the point where the hand of the diamond of the bar and again start the natural anatomy conicity of the root. And this is the action of the smooth part opening beyond the edge the soft tissue. And using this approach, here I did the immediate impression, is very easy to obtain very thick impression in the area of the sulcus. Look here, 0.7 millimeters, 0.5 millimeters. We have always very easy, predictable and reliable impression. And this is the monolithic zirconia crown the day of the delivery. Let's see another case, and I will show you also a video. This is an upper premolar with a huge decay. Patient came in my office because of pain. This is the endodontic treatment, keeping the interaxial bridge of dentin for many reasons that I will highlight later. Build up. Some details of matrixing, showing the seal that we have to obtain. Some stabilization of using liquid dam. And here is the video. Look here the video. I did the gross reduction. I opened the interproximal spaces. And now I go with the bar. With the bar. Look. I go below the chamfer with the sort of slight angulation to go over that area. And after I go again straight, following the natural axis of the tooth. You see that the bleeding is reduced, there is not so much bleeding. And how easy and fast is this kind of preparation? You see? You need to hide just the smooth part in the soft tissue in order to obtain a juxtagingival preparation. If you want to go subgingivally, you have to push a little more. And look here now, this is the occlusal shot before the impression, you see that the soft tissue are open. And this image is very clear. Look here, the soft tissue are open. This kind of openness that we have and how dry they are. There is no blood at all after a few minutes. In this way, it's very easy to fill in that area some light material, light PVS material, and obtain a very nice impression for our technician. And this is the result after 10 days. You see that the healing of soft tissue after this procedure is very, very fast. I show you another case. This was a patient with an old patient with a very deep decay on the mesial of this first premolar. There was also a decay on the distal of this canine. Endodontic treatment using the access of the decay. Here, using Teflon, I have been able to retract soft tissue in order to expose the decay on the distal of the canine. I did a direct restoration on the canine using some transparent matrices. And here again, we have another video. This is what I do on the buccal wall. You have to put subgingivally just the smooth part. Here I'm working with the mirror in the indirect view. I'm working on the distal of this tooth. And here it is another interesting thing. I have recognized along years that when we do the impression on an area without a lot of cervical concavity, there is a high risk of bubbles in that area. Also, the retraction that we have with cords is often not optimal. So when I have to deal with this kind of areas, I work just a bit more with the smooth part of my bath bar in order to open a bit more the sulcus, like I'm doing now, in order to have more impression material in that area. This is some image of the workflow. Here I've been forced to wait a few minutes before taking the impression. But look here the cast, okay? You can see here the quality of the impression that we have. And look here in the mesial side, how much space we have between the tooth and the soft tissue. Look here, you can see here also, because we have this sort of shadow that helps our eye to recognize. You can look here also the edge that we have. Look on the buccal and on the mesial side, and you see with the shadow, this sort of edge that we have. Here we have some step of the lap, the mark, some part of the X-rod work, and here is the finished crown, always by my technician Emanuele Tarascio. And here is the final crown, the day of the delivery. Even here, this has been after 5 days, 7 days, no more than 7 days from the first day of the preparation, and see always the quality of the soft tissue that we have just after 1 week.